It's not going to be as effective, right? So the earlier, the better, because the main mechanism of action is preventing ovulation. It's preventing that LH surge. Because again, like progestin and estradiol, when they're high levels, they inhibit the brain. They inhibit the anterior pituitary from releasing LH. And if you prevent LH, you prevent ovulation. Yes? So that's the main mechanism, but some other research does indicate that it might prevent implantation in some of that early development. Prevents pregnancy in about 7 out of 8 women. That's about 88% effective. Note, it's not 99% effective plus, right? There's a reduction in the overall efficaciousness. It's not meant as a regular birth control. This is a high blast of this hormone that you're getting, and it actually has some risks that go along with it, mainly kind of minor, but sort of significant: nausea, vomiting, stomach ache, fatigue, headache. A lot of times these go along with that big blast of progestin that the female system is getting with the Plan B. Okay, tubal ligation. We talked about this in the beginning. Tubes tied is the way that many people say this. It's 99% plus effective. For some women, it's 100% effective, right? So there's a little range, but it's pretty effective. It's the cut and tying off or clamping of the oviducts. It requires general surgery, okay? Not easily reversible. The risks: pain, bleeding, infection, ectopic pregnancy risk. So this risk does go up a little bit, because now if we've cut and clamped or ligated, tied off the fallopian tube on each side, eggs are still being ovulated, right? They're still being ovulated, so there is still potential that if they get fertilized, they can implant outside the oviduct, on the outside of the uterus, in the abdominal wall. Does that make sense? Because those hormonal things are still happening. There's just no transport mechanism to get the egg or the embryo down into the uterus. And there's this whole system that describes how it's done with the general surgery. There's a laparoscopy sort of setup that has all the little tools down inside of it, little forceps and ligator and scissors and everything that they can work doing this sort of microsurgery. And then a cannula, so there's like a tube and a camera and all the apparatuses that can go right through with small incisions to go right in the pelvis where the fallopian tube is, to cut, resect, cut, and tie off or clamp those two different ends of the fallopian tube, typically close to the fundus of the uterus, or the opening to the uterus, okay? A lot of times who this is done in typically is women that know they never want to have children, and they're set, they've made up their minds, or women that have already had several children and they're relatively young, and they just, I'm going to get my tubes tied, so there's absolutely no risk that I'm going to have another baby because I've had all the babies I want to have. So typically those are who get it. Yes?
I heard that it was a law that they don't allow women to get their tubes tied unless they already have children or they have permission from like their husband.
Oh yeah, that's awesome.
I don't really know about that. Not here in California. There might be some places where, there might be some states actually where there's laws about that, but I'm not familiar with them. I'm not familiar with them, and also there are many single women, right, that don't have a partner or a husband, and they can make that reproductive choice with their specific OB or their surgeon. Like, I'm done. I mean, yeah, I think it probably has some variation from place to place, though. Yeah, Alex.
I think it's a law, but I do know there are some doctors who are really biased and
yeah,
will hire women to do that.
That's probably true. Some bias, some preferential sort of ideas and perspectives of certain medical professionals. And so you guys all, as females and males, can go out. You can be proactive in your medical lives and in your reproductive health and all this, and you can select the physicians and the clinicians and the places that you want to go to. If you experience anything where you're like, oh, I'm uncomfortable with this, or I feel this is not a good situation, leave, go somewhere else. I mean, that's you, that's your health. All right, in a second. Oh, you don't do that? I got to get rid, okay, I'm gone. Diaphragm, cervical cap sponge, these are less common in younger women. They tend to be a little bit present more in midlife or older age women. 76 to 91% effective. Used typically with a spermicide, so they squeeze the spermicide onto it. It's non-oxynol 9. This actually kills sperm, prevents their motility. They get twitchy. I've done studies where I blasted sperm with this under the microscope so I could see what happens. They do not like it. So just that by itself, a spermicidal jelly or cream with non-oxynol 9, knocks them out. This covers the cervix, prevents fertilization, so it prevents sperm from ascending through the cervical mucus, the cervical neck, getting into the uterus, and then into the fallopian tubes. It blocks that passageway. Has to be fitted and done the right way, put in the right place, and remain in the right place several hours after intercourse. What are the risks? Slippage. A lot of times they slip out. Like they slip, they go crooked, they're no longer blocking the opening to the cervical canal. Problems with insertion, problems with removal, irritation. Sometimes they irritate the cervix or cause allergic reactions, infections. Toxic shock syndrome. Some women have forgotten or they left them in too long. And it's this object covering the cervix with the spermicidal jelly on it and everything in the female reproductive tract for way too long. And that typically is associated with toxic shock syndrome. Like leaving a tampon in the vagina for too long. It can cause the same sort of situation. How you put them in, basically you squeeze them sideways, fit them in, and then let them expand with the bowl shape sort of facing down so it's cupping and covering the opening of the cervix or the cervical neck. Expands a little bit in the dimension of the vagina, but helps to sort of cover that region. Female condom is another one. You guys have probably heard, yes? So there's female condoms of different types. These are, again, about 80 to 95% effective. Helps prevent pregnancy and STDs. So it has an outer ring and an inner ring that surrounds the cervix, sort of like the diaphragm or the cap. And then it has an outer ring that sort of stays over the labia and holds the condom in place. So this is another contraception that's been invented. Male condom, 82 to 98% effective, looking at the majority of studies. Best prevention against STDs. Many use this combination with other methods. So typically the condom is done in combination with another contraception for many people. The risks, of course, misuse, tearing, slippage, allergic reactions. So those are things that are commonly reported as an issue. Misuse, not putting it on right, or even tearing or damage to it during the actual sexual intercourse. Vasectomy, some of these are a little graphic. They're cartoons, but they're still, I showed this and my male students that see these and let's go. Females usually are like, yeah, that's fine. No, well, what they do is this can be done, this is 99% plus effective, like tubal ligation. It's only a local anesthetic is done, but it's not easily reversible again. So the vase is injected with a little local anesthesia to cause numbing, loss of pain sensation. Tiny incision is made right over the vase, and then the vase is pulled out with a little hook sort of forceps, just a little bit, so this is connected to the epididymis, right? Epididymis, vas deferens, testis. Pulled out, snip, tie it off, close, allow those to go back in, and they lift the scrotal sac, sort of let it fall back into place where it normally goes, suture it up with a couple stitches, boom, done. It's done very quickly. Despite how horrendous it looks, it's done very quickly. Many men will report experiencing very little pain. Again, it's not easily reversible, because now during this time, if the male's immune system and white blood cells ever see sperm that are released or get outside of the vase to any area, they're going to start making antibodies against their own gametes. So fertility is often reduced, even with a vase reversal, vasectomy reversal. Did you have a question, Michael?
Is there a weight for this?
Is there a what for this?
Are they a weight for this?
Local anesthetics.
Yes, totally awake. You don't have to have general anesthesia. It's not as intricate. It's easy. It's outside of the body. It's a local anesthetic, and then pull it out, snip, close it off, sutures. Here's another view of the same. Here's another view of the same thing, just to make it. Just a couple stitches, sutures are needed, and there's just a little inch piece of it taken off with resorbable ligation, little cords, sutures that close off the vas deferens. I will say that in general, this is not as common as some of these other contraceptive methods, although it's one of the most common in the U.S. So tubal ligation and vasectomy are done in the U.S. Here's kind of an interesting one, coitus interruptus. Take a guess what this means. Yes, the pull-out method. 78 to 96% effective. This is sort of funny. Coitus interruptus, like a Harry Potter spell. I wouldn't recommend this, okay? Right, based on the results, the efficaciousness of this. Removal of penis before ejaculation. No protection against STDs, right? There is also pre-ejaculatory fluid, right? And we've talked about this. And in that lecture series, if you haven't already watched, I go over sort of the male sexual response and talk about pre-ejaculatory fluid coming from the bulbourethral glands, the little Kepler's glands. They put in a little bit of fluid to neutralize acid, and sometimes there's already sperm in there. And if there's sperm there, they come out in the pre-ejaculatory fluid. So many times this is used in combination with other things, like oral contraceptive pill, or intrauterine device, and coitus interruptus. So you can sound like you're saying a Harry Potter spell whenever you say this. If you don't want to say the pull-out method, you say coitus interruptus. This is how scientists will refer to this. The risks, timing. Some people suck at timing. You can't rely on somebody else's timing. Sorry. Sperm is in the pre-ejaculatory fluid, okay, so the pre-cum or pre-ejaculatory fluid. No STD protection because, you know, there's combining of fluids and everything right there in contact. All right, male hormone contraceptives, progestins, synthetic androgens are being tested, GnRH antagonists, that means these block, they act like the opposite of GnRH. They kind of block receptors that the GnRH hormone would act on, so they prevent GnRH pathway. All these inhibit FSH, LH in the male anterior pituitary and therefore production of sperm. So it halts production of spermatozoa and meiosis and development of the sperm. Remember, this is the hypothalamic pituitary pathway we've talked about. Some of these synthetic androgens, progestins, GnRH antagonists will inhibit these components of this reproductive axis. And if you shut that down, you shut down gamete development. And again, like an OCP, it's reversible. Stop it, the system goes back to the normal pulsatile secretion of GnRH, FSH, LH, production of gametes, sperm production comes back up again. They have pill patch injection and implant. A lot of recent studies in the last especially decade on this, and in places like the US and Europe and other Asian countries, they're already in testing phases, and a lot of men are willing to participate. Surveys have looked at this because you might assume we have such a, you know, sort of a gender biased society and there's so much that's on the woman, right? It's usually expected the female do this, the female do that, oh, it's the female's fault. A lot of this, but when men are surveyed in a lot of countries like the UK, USA, parts of Europe, the men, majority of the men are like, yeah, I'd be willing to do that. Yeah, of course, women do it. Like, just take a pill or I get an injection or a patch and it helps guarantee, I would be willing to do that. So some of, you might think they wouldn't, but the majority of men report that they would be willing to do this. Yeah, Tatiana.
I heard about a study like 2 years ago where they were doing that and a lot of men were stopping it because they had like nausea, headaches, all this stuff that like women get with OCPs, and it was just really funny.
Okay, so that is true. There are some little contraindications that of when it would be good to do this, and there are some side effects that come from some of these different types of newer experimental sort of contraceptives for males. I think the side effects sort of vary based on the different type that they were trying. But yeah, I've seen that, yeah. So, and those are side effects that a lot of females like experience, right? Those are sort of, they come along with some of those things, like bloating and weight gain and some of those other things. So the growth of the world's population, I'm just gonna say, because this links into contraception. This is not only giving you know, men and women their proactive power to decide when they want to conceive, when they don't want to conceive, controlling their reproductive life and their life in general, but linking this into sort of the world's population and where it's going, it's exponentially expanding. Right? So if we look in the year already, now we're past 2000 now. This is 2011. Now we're getting up to 2020. But exponentially growing. Now we're about 8 billion. I don't know what the actual number is now. It's ridiculously high. This was a prediction several years ago, just going based on country, what proportion of the world's population is expanding in these different areas, with the most growth in Asia and Africa. And then here we are, North America, Latin America, Europe. But here we are about midway through, and the prediction was about 8 billion. That's about where we're at. So exponentially increasing in population. So contraception actually ties into that. Because if nobody was practicing any kind of contraception, can you imagine? There's predictions of that too. It's ridiculous. And actually we are exceeding the Earth's carrying capacity. That means the resources and the habitat and the ecosystems that are able to provide for that many living organisms on it, we're exceeding that. And that's why we're seeing emissions and global greenhouse gases and global warming and rising in temperatures and pollution and plastics and everything everywhere. We are now exceeding the carrying capacity of the Earth. So that links into contraception. So that's an element, the social, personal element, and having a woman or a man have their own proactive choice and discernment of what they want to do in their reproductive lifespan, and the Earth in terms of sort of the population of the Earth and what we're looking at. We are not going to have enough time for this, but I'm at least going to get into it. Abortion rates in the U.S. So there are some images in here and some things that might, I don't know, cause some negative feelings. I'm trying to present it very scientifically based on the facts, what's there, and the biology of what this process is, and the rates and the numbers. Abortion rates in the U.S. sort of were up high. Roe versus Wade, 1973. Then, okay, this is per 1,000 women, so 30 per 1,000 women. and then sort of plateaued out, and then started to go sort of down in the early 2000s, actually reaching sort of the lowest, getting lower and lower in developed countries, in North America, and in Europe over time. So there was kind of a surge, it kind of went up, and then it kind of plateaued and started to come back down. This is just census numbers looking at women in developed countries versus North America and Europe. In 2014, there was an all-time low. And a lot of these are good, reputable sources. They are not coming from individuals or lobbyists or sectors that are like anti-abortion or pro-abortion. These are people that are taking census information, how many abortions were done, how many clinics were available, what are the laws, what do the numbers look like. So, and this was from CNN, so I just took this so you could show the number of abortions per 1,000 women. If we take it all the way up to 2014, it was the lowest ever. And it's still kind of right along this trajectory, even right now, 4 years later. 14.6 women out of 1,000, so all-time lows. Likely due to, we don't really know why, there's a lot of speculation as to why, likely due to improved contraceptive use. Women and men are like, you know what, hell no, I don't want to get pregnant. And I have my life and I have all these things planned. I'm going to do this, I'm going to be compliant with however I need to do this. So being much more proactive in terms of how to do contraceptives the right way. There was also a wave of abortion restrictions in several US states, and those really started ramping up in 2013, 2014, 2015. We're seeing them again now and in full force and even stronger. And actually we have a group that's going to present on abortion and new laws, yes? So we're going to hear a lot more about this, so I don't want to spend too much time on this. What age group gets the most? Some of these studies, this was later, this is in 2000s. Some of these census studies, they only come out every like 5 or 10 years. So they get a bunch of data, and once they have enough, they actually do a little plot and look at it. So it looks like 15 to 17, very low. The majority, 20 to 24, 25 to 29, 30 to 34. Sort of the majority in those age groups. So that's sort of, and I will say there's some other information about census numbers of abortions and where they're done. About 75% of abortions happen from individuals in lower socioeconomic level or poor, in general more poor. So a lot of the numbers are actually in that area. Another surprising little stat in there is that about 2/3 of women that undergo abortion already have 1 or more children. So despite these, and you'll see some of these later ages, like in the late 20s and the 30s, many of those, about 2/3, already have a child. So it's not like it's a first-time pregnancy. There's already children. They already have a family. So when are most abortions performed? Again, in the time span of the actual pregnancy, the majority are done at less than 9 weeks. And then about 20%, a little less than 20%, 9 to 10 weeks. And then it gets lower and lower and lower. Okay? So these numbers are super low when you get out to the second trimester out here. First trimester is by far and away the highest proportion of when that is done. This goes through all the different types and timing of when an abortion is done and how. So there are different clinical methods, techniques that can be done. This is again from the last menses, so they're saying like day 0, and then weeks, first trimester, second trimester, 12 to 24 weeks, 24 weeks to like 38, that's third, okay? So these all have a legend right here, and I'm not going to go through every single one of these, but they go through when is the most common time, for example, to do the abortion pill. And this is one of the easiest because you can take a pill followed by another pill, 24 hours, and it causes a miscarriage, basically an induced miscarriage, an induced abortion. And that right here is standing for MM. It's a mifepristone or methotrexate and misoprostol. So it's the MM combination that actually causes a shedding of the lining and removal of the early embryo. So typically this is done, and this is not exactly right because you can do it a little bit longer, but it's right in between 4 weeks to about 10 weeks. That is typically what is considered like the abortion pill. So that requires no dilation. That means you have to open up the cervix, right? Sometimes they put a little laminaria tent in there to kind of open up and use a speculum to open. And then things like curettage where they basically use, it's almost like a spoon sort of structure to kind of remove and evacuate. Dilation and evacuation, sort of pulling out, taking out. Notice all the way at the end though, if you're in the 3rd trimester, if someone's in the 3rd trimester way out here, you have to do a dilation and extraction. So kind of pulling out, dilating and then pulling out parts of the developing fetus, or a hysterectomy, standing right here. That means you have to remove the entire uterus. right? So it's that sort of large that you cannot do it by some of these other means. So vacuum aspiration, so this would just be vacuum aspiration that can be done sort of at the end of the first trimester, around that range. A speculum goes in, it opens the vagina, opens the cervix, and then a curettage unit, basically it's a suction that's attached to a little apparatus so you can just sort of suction it out. They make sure they have the uterine lining, the embryo, try to make sure that everything is there, because if something is left behind, that can cause complications and problems and infection and stuff in the woman, and cramping and excessive bleeding. So try to make sure that everything is got. The laminaria tent is usually put in to help dilate the cervix and open it up, especially further along. So if it makes it a little bit easier to get the speculum and get the curettage and everything in. Some of these dilation and curettage, this would be done on a 9-week. So this is about 9 weeks around that time frame. Again, speculum, cannula, and then the little curettage where they can basically make sure that you're getting the entire endometrium and the placental tissue so that everything can be removed and taken out or suctioned out. This one is a little more graphic, and this is just the size. Based on the size at this point, you're getting into the end of the second trimester. So dilation and evacuation is called a D&E. So they have to dilate with the laminaria tent, insert the speculum, and then sort of pull out in pieces and then make sure that everything is sort of removed. I realize that that is graphic, but that's sort of the time and space of how big it is. There's another type, it's called intraamniotic injection, and that also can be used to induce a late second trimester abortion. They insert saline solution, urea, glucose, or another cocktail prostaglandin. Helps to induce actual sort of contractions and removal of the fetus at this point to help sort of induce the actual abortion to start happening. I will just end on there's important, so those are kind of the factual parts of when they're done and the timing. The risks, of course, are bleeding, infection, incomplete abortion, where there still is remnants that you have to remove, uterine scarring, cervical damage, sepsis, so infection inside of the body. And then the emotional complications are, of course, guilt, depression, sexual dysfunction, alcohol, and drug abuse. So I want to emphasize that counseling, dealing with, and grieving is really important. If any woman ever goes through this process, that's a really, really important part of it that you should not